All right,
Okay,
Dr. Jamila,
thank
you have the
you.
floor.
Good morning, our teachers and facilitators and fellow colleagues. This morning I'll be taking practice question 4B. Please, can I be heard?
Yeah, you can be heard.
Okay. Okay, the question is about a 68-year-old lady with a 10-year history of rheumatoid arthritis, well controlled on methotrexate and etanercept, who presented with a 2-day history of left knee pain and swelling, which is warm and tender. So one, what urgent step will you first take about this patient? What investigations will you do? How will you manage this patient? Features of osteoarthritis on X-ray and clinical features of rheumatoid arthritis, and then what is the most likely diagnosis? So the urgent first step I'll take is a knee joint drainage using needle aspiration. Other approaches that could be done for the knee joint drainage are arthroscopic or arthrotomy. So for the investigations I would like to do a synovial fluid analysis and culture. And part of the things I'll be looking out for are a gram stain, cell counts, polarized microscopy, and then culture and sensitivity. I also want to do a blood culture to increase the yield of the likely causative organism. And then if none of these yields, then I may want to do a nucleic acid amplification test. Then also procalcitonin levels would also be helpful in this patient. Now, it's been said that for the synovial fluid procalcitonin levels, it has a higher sensitivity than the blood procalcitonin level. However, for the blood procalcitonin levels, it's more specific. Then I also want to do other supportive investigations like a full blood count, erythrocyte sedimentation rate, and C-reactive protein, which may be deranged. The full blood count may show leukocytosis or neutrophilia if there is coexisting septicemia or sepsis. And then the ESR and CRP may also be elevated in these patients. And I also want to do a plain X-ray of the knee joints or an ultrasound scan or magnetic resonance imaging to look out for any bone involvement and also to have a baseline of the bone status involved in the joints. Then other supporting investigations I want to do are electrolyte, urea and creatinine, uric acid levels because of other possible differentials like a crystal arthropathy, and also this patient has a septic process ongoing and is a background rheumatoid arthritic patient, so it's also be good to look at her renal function. Then for the anti-CCP and rheumatoid factor, I put a query there because these are diagnostic and this patient has already been diagnosed with rheumatoid arthritis, so I may or may not do it. So for managing these patients, after obtaining a good history, examining and investigating these patients, I want to involve important specialists, which will include the rheumatologist, the orthopedic surgeons, infectious disease specialists, physiotherapists, medical microbiologists, and the nurses. And I'll immediately want to commence joint drainage and empiric antibiotics pending culture results, which would ultimately inform the decision choice of antibiotics in these patients. So I could commence intravenous flucloxacillin, 2 grams 6 hourly, or if I suspect a methicillin-resistant staph, I could use vancomycin. Now, for these patients who has rheumatoid arthritis and has been on methotrexate and etanercept, it's an immunosuppressive state because even the medications she's on could cause immunosuppression. So I would have concern for gram negatives like Pseudomonas. So I could add a fluoroquinolone to the antibiotics. So if the initial gram stain demonstrates a gram-positive foci, so I'll suspect Staph aureus, which is the most common causative organism, and then place these patients on vancomycin, like I earlier said, for MRSA. And then if it's methicillin susceptible, then other antibiotics that could be used are flucloxacillin, cefazolin, or oxacillin. Now, if the gram stain shows a gram-negative bacilli, then the suspicion for Pseudomonas will really be strong, and then I would continue with the flucloxacillin and fluoroquinolones, or use a cephalosporin that has Pseudomonas cover like ceftazidime or cefepime. Now, after about 2 to 3 days of commencement of these antibiotics, I expect some improvements in her symptoms like the pain and even the limitation of movements. So physiotherapy could commence. And then also while this patient is on treatment, I want to monitor the inflammatory markers to have an objective assessment of improvements in her clinical condition. Then because of the background rheumatoid arthritis, I also want to consider withholding the immunosuppressants she's taking to prevent spread or worsening of the septic process, which is ongoing. So I want to withhold the etanercept and methotrexate until there's resolution of the septic arthritis and then recommence. Or I could also place her on a DMAT that is mild and doesn't have, strong immunosuppressive actions like hydroxychloroquine. So for the features of osteoarthritis on X-ray and clinical features of rheumatoid arthritis, for osteoarthritis, there could be joint space narrowing, subchondral sclerosis, subchondral cyst, or the presence of osteophytes. And then for rheumatoid arthritis, they could have pain, swelling, and early morning stiffness of the joints, especially involving the metacarpophalangeal and proximal interphalangeal joints. RA classically spares the distal interphalangeal joints and is usually symmetrical. And then other joints can also be affected. Patients could also have weight loss, depression, fatigue, other extra articular features like episcleritis, scleritis, then investigations could show features like anemia. Then the patient in advanced situations could have nodules or deformities like ulnar deviation or swan neck. And then also when you examine these patients, their joints could be swollen or tender. So the most likely diagnosis in these patients is septic arthritis, and this is most likely because of the acute presentation of the joint swelling, pain, and the warmness, and then the fact that she has background rheumatoid arthritis, which makes the joint predisposed because the joint is diseased. And then also she had been on etanercept and methotrexate, which are immunosuppressants that could also predispose her to septic arthritis. So I just added this slide for possible differentials like rheumatoid arthritis, flare. That's where the history would come into play. If it's a rheumatoid arthritis flare, it may not be as acute as the septic arthritis. And then when we aspirate the fluid in the septic arthritis, it may be purulent. And then the procalcitonin levels could also help to confirm or differentiate septic arthritis from rheumatoid arthritis flare. Other differentials include septic bursitis, reactive arthritis, gouty arthritis, pseudogout, or osteoarthritis. So briefly talking about septic arthritis, it represents an invasion of the joint space by microorganisms, most commonly bacteria, and it's increasingly becoming responsible for emergency care visits. And it commonly arises via hematogenous seeding, and bacteremia is more likely to localize in a joint with pre-existing arthritis, like this index patient of ours. And then also injection drug use is becoming increasingly an important risk factor for septic arthritis. So the predisposing factors include advanced age, pre-existing joint disease, recent joint surgery or intra-articular injections, skin or soft tissue infection, injection drug use, presence of indwelling catheters, and then the presence of immunosuppression. So briefly about the pathogenesis, septic arthritis usually develops from hematogenous seeding, direct inoculation, or continuous spread from an adjacent tissue or bone infection. So for the hematogenous seeding of the synovial membrane, this is the most common mechanism, and it most commonly involves large joints. And the most common organisms are usually organisms that easily have predilection for joints that have do not have the limiting membrane. So example is the Staph aureus, and it's actually the most common causative organism for septic arthritis. So for direct inoculation, this could be from bites, wounds, trauma, or intra-articular injection, and then there could be contiguous spread from conditions like osteomyelitis. So once these organisms localize to the joints, they initiate the inflammatory cascade, and then the patient presents with symptoms. So for the microbiology, numerous pathogens can cause septic arthritis, and this actually depends on the mechanism, just like we saw that it's most commonly Staph aureus from hematogenous spread, and it's usually monomicrobial. And then methicillin-resistant Staph aureus is now the most common cause in adults. Other gram-positive organisms can also cause septic arthritis like streptococcus pneumoniae. Then gram negatives are more common in older adults, in immunosuppressed patients, like in our index case, and then also those that use intravenous um, drugs. Then polymicrobial septic arthritis is rare. However, it can occur following conditions like penetrating trauma, small joint septic arthritis, or in patients with polymicrobial bacteremia. So this table just tries to look at the possible causative organisms and the clues that we could get from the clinical history. So we can look at this later. So for the clinical manifestations, it's usually of acute onset with pain, swelling, and warmth of the joints. Then there can be fever, and then in the elderly patients, they likely will not present with fever. Then there's restricted joint movements, and then we said that the knees are usually involved in most of the cases. However, the wrist, ankles, and the hips could also be involved. Then polyarticular infections are seen in sepsis, underlying rheumatoid arthritis, and even when there is other connective tissue disease. Then it can also be a presenting feature in patients with infective endocarditis that use intravenous drug use. So on examination, there could be swelling, erythema, warmth, tenderness, effusion, and then limited range of movement. So for the diagnosis, it's based on synovial fluid analysis and culture. And then it could be definite if the gram stain or culture is positive. So the diagnosis could be presumptive if synovial fluid is purulent with a leukocyte count the synovial fluid of greater than 20,000 cells per microliter with predominance of neutrophils and a negative culture. So even if that is present, it shouldn't deter the use of antibiotics. Then blood culture could also be done to increase the yield, and it's advised to take at least 2 sets for both aerobic and anaerobic assays. Then we talked about the radiologic assessments to look at the bones, and then also nucleic acid amplification test, especially when cultures are negative and we suspect Neisseria gonorrhoeae. Then we talked about procalcitonin levels. Then if osteomyelitis is concurrent or contiguous in the patients presenting with features of septic arthritis in that joint, then synovial biopsy can be done to improve the yield, or also if there is suspicion of co-infection with slow-growing organisms like mycobacterial tuberculosis. So the biopsy comes in these situations to improve the yield. And also if there is failed joint aspiration or sampling, then a synovial biopsy could also be used. Then others include synovial fluid for polarized microscopy. So we talked about crystal arthritis being a possible differential. So we could see that, or sometimes it could actually even coexist in patients that have a disease joint from this crystal arthropathy. So that could also point to the presence of those conditions. So we also talked about other supportive and non-specific investigations. So this table shows synovial fluid characteristics. So for a non-inflammatory arthritis like osteoarthritis, the white blood cell count is usually less than 2,000 cells per microliter, while in inflammatory arthritis like rheumatoid arthritis, it will be between 2,000 and 20,000. And then in septic arthritis, it's usually greater than 20,000. And depending on the causative organism, it can be as high as 100,000. And then for the neutrophils, in non-inflammatory, it's less than 25%. In inflammatory, it's about 50 to 75%. And then for septic arthritis, it's greater than 75%. And then for the cultures, stain for microorganisms, there is no yield in the non-inflammatory and inflammatory arthritis, while in septic arthritis, it may be positive depending on the organism or prior antibiotic use. So for the treatments, like I mentioned, it's usually multidisciplinary, and it's very important to immediately commence joint drainage and antibiotic because it's like an enclosed abscess which can destroy the joints if no stringent measures are taken immediately. So I spoke about the joint drainage, which could be bare needle aspiration, arterioscopic or arteriotomy, that's the open surgical. And then for needle aspiration or arthroscopy, it's good for the knees, elbows, ankle, and the wrist joints. And then arthroscopic routes are better for the hip, shoulder, or semiclavicular joints. Then we talked about the other supportive therapies like physio, treating background comorbidities and monitoring parameters for the progress. So for antibiotic therapy, it's initially empiric until which you cover for the most probable pathogen in the environment, and then ultimately guided by the antibiotic choice. So we talked about the fact that if the initial stain shows a gram-positive cocci, we could use vancomycin if we suspect MRSA, or if the susceptible Staph aureus methicillin susceptible is suspected, the antibiotic choices could be of oxacillin, nafcillin, flucloxacillin, or cefalozolin. And then alternatives to vancomycin, because some patients may react to it or have contraindications, so you could use drugs like clindamycin or daptomycin. And then if it's a gram-negative cocci, we need to cover for Pseudomonas, and the antibiotics could be ceftazidime, cefepime. And then this should, or we could combine a beta-lactam like the flucloxacillin you mentioned earlier with an aminoglycoside of fluoroquinolone. So for these patients, index patients, I actually went more with fluoroquinolones because she's elderly, has other comorbidities. So I'll avoid the aminoglycosides in her to prevent any renal deterioration. Then we talked about the gram. If the gram stain is negative and there are no concerns for Pseudomonas, the patient is immunocompetent, we could use vancomycin or vancomycin plus a third generation cephalosporin like ceftriaxone. And then ultimately, of course, the blood culture results should guide the antibiotic choice. So in conclusion, septic arthritis is an emergency that requires prompt joint aspiration and antibiotic therapy, as it is an enclosed abscess that can destroy the joints, and hematogenous seeding is the most common mechanism, with Staph aureus being the most common causative organisms. However, in the presence of background comorbidities like immunosuppression, we should think of other causative organisms like the gram negatives, and multidisciplinary approach is key to achieve the best of outcomes. Thank you for your attention.
Yeah, thank you very much, Dr. Jamila, for a wonderful presentation and setting the pace and presenting within, the time. So any contribution, Dr. Sawa, you can start sharing your slides while we welcome contribution, questions, clarifications. Dr. Chibuike say, is there any room for meropenem in severe conditions? Dr. Jamila, can you hear me?
Yes, I can.
Yeah, so
Okay,
Chibuike.
okay, thank you for the question. In the course of preparing for this, I didn't really come across any specific guidelines that clearly spells out the antibiotic regimen, but I don't know if the rheumatologist would help with that. But I would think that the carbapenems would play a role in severe disease. And then if there is suspicion for Pseudomonas also, it may also cover, especially in penem. So yes, I would say so.
Okay. Thank you. Any other contributions? The rest of the contribution is they're applauding you. Dr. Esther say, any worries with fluoroquinolones in the elderly?
Okay, thank you very much. So for the fluoroquinolones, actually, initially they were taught to increase the threshold for seizures in the elderly, but more research has been done on that issue, and it's been found that there is actually nothing to worry about in the elderly, except there are specific contraindications, like the patient has reacted to fluoroquinolones in the past. So there's really nothing to worry about. Well, it stands to be corrected though.
Okay. Any other comments? Okay. Dr. Etubi saying there are some predictors of poor outcomes, including age older than 60 years, infection of the hip or shoulder joints, underlying rheumatoid arthritis, positive findings on synovial fluid cultures after 7 days of appropriate therapy, delay of 7 days or longer. Okay, delay of 7 days or longer in instituting delay of 7 days or longer in instituting therapy. Okay, so delay in instituting therapy, positive culture after a week of appropriate therapy, age greater than 60, and infection of the hip or shoulder. are all
Okay, thank you very much.
predictors. Yeah. Could you
Okay,
please,
thanks.
Dr. Margie, could you please restate what you said about withholding immunosuppressives in this patient?
Okay, so I said in this patient, she's a rheumatoid arthritis patient, and she has been on etanercept and methotrexate, which are immunosuppressants, and she's actually undergoing a septic process at this point. And we know that continuous use of those drugs could actually, worsen or propagate the spread. So I'll be cautious in continuing them. So I would actually withhold and then recommence after resolution of the septic arthritis. However, other DMARDs that are mild, that don't really have significant immunosuppression, like hydroxychloroquine, could actually be instituted in this acute phase of the septic process before recommencing. So I don't know if
Okay,
the
yeah. So,
rheumatologist or ID specialist could.
okay, thank you. So, Agu is asking for tendon rupture or tendinitis from chloroquine. No, yes, that's a general. It's not specific for somebody with septic. It's a general. Side effects for chloroquine, even though it's a rare side effect. Dr. Zakaria is saying, will it be appropriate to capture the background RA in the diagnosis?
No, well, I don't think it would be bad, but what's glaring here is the septic arthritis. So I think if you mention septic arthritis and then the background rheumatoid arthritis, it's still okay. But the
Okay.
emphasis should be on the septic
Yeah,
arthritis.
the septic arthritis. All right, thank you very much for responding. Any other contribution from our teachers before we move to the second presenter? Okay.
Hello, Dr. Kute.
Yes, sir.
Yeah, it was a beautiful one. I think I just have a little correction. I thought I heard her saying that quinolones was thought to increase seizure threshold. Is reduced, not increase.
Yeah.
Oh, yes. Thank you very much, sir. Thank you, sir. That was a mistake.
Thank you.
Okay, sir. Thank you very much, sir. Well, Dr. Yusuf Rahim will say, what urgent step will be taken first in the management of this patient?
Well, I thought it would be the knee joint aspiration. I don't know if he thinks otherwise.
Yeah.
Dr. Atta,
Yes, ma'am.
since our aim is to answer 3 questions, the Dr. Jamila
Yeah.
has done so well.
Yeah.
And he answered that question was really lucid, answered it beautifully well. So I think we should take the next presentation. Dr. Jamila, thank you so much. That was a lucid presentation.
Thank you, ma'am.
All right. Thank you, Dr. Jamila. Dr. Sawa, you have the time now. Can go.
All right, thank you very much. Good morning, everyone. This morning, my name is Dr. Sawa Francis. I'm taking the practice question 1B, October 2022. Okay, and it goes. A 55-year-old male with a history of fever who was not seen by his colleagues for days was found unconscious at home. He was brought into the emergency department with an altered sensorium and 2 focal seizures of his right extremities. He had fever of 38.5 degrees Celsius, BP was 90/54, and pulse rate with a tachycardia of 124 beats per minute, and the respiratory rate was 24 cycles per minute. The question says, list 3 differential diagnoses and give reasons. B, mention 5 relevant investigations in the emergency unit. So by differential diagnosis, 1, it would be brain abscess as a result of the fever and the focal seizures the man presented with. Second, it will also be encephalitis, likewise for the same reason, because he had fever and altered sensorium. I could also consider possibility of hyperglycemic emergency in this patient because of the loss of consciousness he had. Other possible differential accounts also add this possibility of the sepsis, likewise because of the fever. So mention 5 relevant investigations in the emergency units that could be done for him. One, I would want to do a random blood sugar, considering the fact that I'm looking at part of my differential is a hyperglycemic emergency. And if it's going to help me to confirm whether there is an elevated blood sugar or even a hypoglycemia also give me altered sensorium. Secondly, I want to do a urea and electrolyte with creatinine. It's going to help me tell me whether if there is electrolyte derangement or renal impairment in the patient. Then another thing I would also want to do is arterial blood gases, looking out for derangement in either as a result of acidosis or alkalosis. So any derangement in the blood gases also lead to the clinical presentation the patient had. Urinalysis is also an important investigation I want to consider in an emergency department. I'll be looking out for either proteins in the urine. I'll look at also for presence of ketones, particularly I'm thinking of hyperglycemia in this patient because those hyperglycemic emergency, either DKA or HHS, it could also be telling for me. Full blood count differential ESR is also an important investigation I would want to consider. We want to look out for evidence of infection and any other derangement. ECG is also an important investigation I want to quickly do because possibility of the patient that will have some acute coronary syndrome will also have present in this similar fashion, and cardiac enzyme also with urgent brain imaging. Now the question goes further again and says the investigation shows the BBC of 20,000 with neutrophils of about 86%. Potassium was 3 millimoles per liter. It was obviously reduced. There's hypokalemia. Then sodium was 131 millimoles per liter. Chloride was 95. Bicarbonate was 17. And I had a trace of ketones and leukocytes with nitrites of 1+ on urinalysis. The lactate was elevated at 4.5 millimoles. Urea was also elevated, and creatinine was elevated. We are not giving any value specifically, particularly with respect to creatinine. So the random blood sugar was markedly elevated at 8.8 millimoles per liter, and the cranial CT scan was normal. pH was 7.34. Partial pressure of CO2 was 35, and that of oxygen was 78 millimeters of mercury. The question now goes further to say, what is your final diagnosis? What in the above findings support it? So my final diagnosis is going to be HHS precipitated by sepsis, the focus being UGS complicated by shock. And in the findings that support this, my diagnosis, one, because of the markedly elevated serum blood patient had, because usually patients in HHS actually have very markedly elevated serum glucose. It used to be said that their blood glucose is usually about 600 milligrams per dl. This patient is having above 600 milligrams per dl. The ketones might or might not be both present. If they are, they're actually not that markedly elevated as compared to we find in DKA, likewise, which is what this patient had just a trace of ketones. There's possibility of loss of consciousness also because of the change in modality that tend to affect mental status. Fever, he had dehydration with hypotension, tachycardia, and tachypnea. There's neutrophilic leukocytosis, which is an evidence of infection, most likely to be the as a result of the infection UTI he had that precipitated this HHS. There's azotemia and electrolyte derangement, and this arterial blood gases were almost normal. There's really no marked acidosis like that as you can find in DK. I will talk about some of the nuances about DK and HHS just shortly. Now, we said outline your management. First and foremost, I would want to ensure basic principles of safety on this patient to ensure that the airway is patent, his breathing and circulation is adequate. I will establish immediate IV access, and quickly do the arterial blood gases, check for lactates, check for ketones, electrolytes, and urea, take blood samples for microscopic culture and sensitivity, and also that for urine. I want to continue to monitor the urine output as it forms important part of my fluid analysis and ultimately in management of this patient. I want to do a 1 to 2 hourly monitoring of random blood as well as the other parameters like arterial blood gases, the UCR, and urine output. Importantly, in this patient, I will want to continue to monitor the potassium hourly because that is one important electrolyte that is likely to cause mortality if it is not handled properly. So IV fluid replacement in this patient is one of the key cardinal most important pillars of management of this patient, because oftentimes they are markedly dehydrated. Their form of dehydration is much more severe than what you find in kids. It's said that people with HHS are actually up to about 9 liters deficient. So I would want to ensure that appropriate IV fluid replacement with 0.9% normal cell line is adequate. I'll talk about the more details how we tend to do that IV fluid replacement. Oftentimes, if the IV fluid replacement is adequate, sometimes you might not need to go further to give insulin because it tends to even correct and bring down correct the hyperglycemia. Then importantly, again, I want to treat the infection, which is the likely precipitant in this patient. Insulin treatment might also be required in case if I from rehydration, adequate rehydration, we are still having markedly elevated random blood sugar. Potassium replacement and correction of electrolyte is also an important aspect of management of this patient. But that is going to be guided also by the hourly monitoring of the potassium of the patient. I will also talk about that subsequently, how we do potassium replacement. Importantly, also, while we are doing that, it's important to avoid hypoglycemia and also precipitous and rapid decline in the patient's blood sugar, because that could also lead to another catastrophic emergency that we are trying to avoid. So it's supposed to be a gradual reduction in the patient's random blood sugar. Anticoagulants prophylaxis is also very important in this patient because of the high osmolality, they tend to be at risk of developing thrombosis. So anticoagulants is also an important aspect that I want to consider in this patient. And lastly, secondary referral if there's need. We want to consider dialysis if the patient has been established to have renal impairment that is refractory and not coming out of even after adequate medical management. ICU or HDU care will also be appropriate in this patient if the condition is not abating. So we want to talk about hyperosmolar hypoglycemic syndrome just briefly using this following outline. HHS is a clinical condition that said arises as a result of complication of DM, and this problem is most commonly seen in patients with type 2 diabetes. First described around 1980, mostly in patients with 1880, mostly in patients with DM. They usually present with profound hypoglycemia and glycosuria. They usually don't have this classic symptom of small breathing or acetone.
Hello.
Yeah.
Hello. Can you hear me?
Yeah, I can hear you.
I don't know, Dr. Okute, do you think we should go through HHS? Is it really, if we are finished answering the questions, maybe you just send them the HHS slide so that we can contribute, and then the other person will present, so that we'll have 3 presentations today if possible.
Okay, sir. I think I agree with you. Dr. Sawa, I don't know, is there any highlights that you want to highlight that in this presentation, so that we don't take all the slides that you proved? Any highlights only? Well,
actually, maybe I really don't know. I think we have taken HHS severally on this.
So if there are no highlights, so probably let's invite questions, contributions, and then if there are any clarifications, so you just make, And probably if you need to refer to your slides, you can refer and then make the...
No problem. Time is up.
Okay. All right. Dr. Shamsuddin said, I think you need to calculate osmolality and anion gap to support your diagnosis. Dr. Olalekan said, can one make a diagnosis of HHS without having the plasma osmolarity? This patient plasma osmolarity is difficult to calculate because of the serum that was not given, or the serum electrolyte. The electrolytes, Dr. Sawa, were not... Hello,
Okay.
can you hear me?
Hello, yeah, I can hear you.
Investigations that they gave, is it possible, I didn't see the investigations, is it possible to calculate the osmolarity from there?
Just
Okay.
go back to it. Just go back to it.
Let me go back to the question. All right. So we have serum blood glucose. We have our sodium. Okay. So with this, and although we are not given urea, they just told us that urea is elevated. Yes, it might be difficult to calculate serum osmolality.
So what you do is you can calculate without the urea. Then since urea is elevated, you can assume it's between 7 or 10. And see, even without the urea, what happens? What can you get something important? So why don't you try and calculate it and see?
Well, I'm not sure if I know what to use in the absence of urea, but I'm looking at the random blood sugar of 38.8 millimoles per liter.
You know the formula, right? What's the formula?
Yeah, 2 times sodium plus glucose plus urea.
No, 2 times sodium plus potassium first. Sodium plus potassium times 2, right?
Yes, in brackets. Yeah.
So which is 134 times 2, which will give us 268. Okay. Plus the glucose. Which is glucose is 38.
38.8.
So 8 plus 38 is already 306 or 306.8. Okay. So you can add let's say 10. So about 316 or thereabouts. So let's assume.
Okay, so if we can just assume the value of urea, since they said urea is elevated, and make the calculation.
Most likely, maybe it will be given in the exam. This is a recall, mind you. So, but if it's elevated, you can assume, yes, you can assume that.
Hello, sir.
Okay. Yeah. Who's... Okay.
Hello. Yes. Yeah. Sorry, please,
okay,
just a quick contribution. Because I felt even without adding, good morning, everyone. Even without adding the urea, the serum osmolality is already elevated. So you can even assume that it's already HHS. Since the normal value is usually between 270 to 290. So we've already calculated 3 something now, even without adding the urea.
Yes.
So I think that can even go, even without giving the urea in the exam. Yes.
Exactly. Thank you. Yeah. Thank you,
Sorry,
Dr.
please, can I say something?
Dr. Jamila? Yes, yes.
Okay, thank you very much, Dr. Sawa, for the lucid presentation. So in the absence of urea, we can actually use the effective osmolality. That has been validated. So that's you multiply the sodium by 2 and then add your glucose in millimoles per liter. So you don't need the urea, even if the value is not given, you shouldn't get worried. You can calculate the effective osmolality. So the sodium here is 131. So if you multiply by 2, that will be 262, right? Yes, then you add the random blood sugar in millimoles per liter. Yeah, so that's fine.
Okay, thank you very much.
Yeah, and that will give 300. So, but the effective osmolality now, what value are we looking at that is significant?
It's still where the 30, like for HHS, when it's more than that, it's just like an alternative, because the urea is not available. I don't know if there's any endocrinologist that could just validate
Okay,
that.
good morning, everyone.
Yeah, good morning.
Good morning. It's like my network is logging. So there is this concept of effective osmolality. I don't know whether you can hear me.
Yeah, we can hear you, ma'am.
Okay, so you don't need urea and potassium because urea and potassium, especially the urea, is freely moved from the intra to extravascular compartment. So, and that's why the concept of effective osmolality now came into being used. So you don't use to add urea, then also potassium, because it does not really contribute to the osmolality. So you don't use that. So once you have 320 and above, it is. And if you have a sodium and you have hyperglycemia, you need to correct for that sodium, because this sodium you're seeing is not a true picture of the sodium. So, and you have 131 and your glucose is 38. So you need to correct. So for every 5.6 millimole rise in glucose, there's a 1.6 millimole drop in sodium, what you will see. So you need to correct for that. So if you have to do the corrected sodium, and that's what you use. So if you do that corrected sodium, I think it is going to be, I've not done it, but I think maybe it's going to be around that 140 something, because it's very important, especially when it comes to fluid management, giving normal saline, because you only give if the patient is severely dehydrated to expand the intravascular compartment. Once you expand, then you change to half strength normal saline, because if you continue using, you will not know, you'll be tilting the patient to hypernatremia. So you need to correct that sodium to calculate your osmolality. Thank you.
Okay, yeah, thank you very much, ma'am, for the contribution. Okay, let me go to the chat box.
Sorry, before we leave this corrected sodium, the question then will be, what will be our baseline for the blood glucose? Now it's 36.8. So what will be the baseline that we're using for the correction?
No, you use that 38, 36 or 38. You use it. So there's a formula, corrected sodium into what you're giving, into 5, what you have the glucose minus 5.6 divided by the 1.6. So there's a formula for that. You do it and you add.
Okay, so what you do is to help us get the formula and post it so that we'll know.
Okay, Dr. Jafaru posted it on the chat. He says sodium plus 0.4 in brackets, glucose minus 5.5, all in brackets. So I don't know. Yeah, that's Jafaru. That's what he posted. So when you do 38.8 minus 5.5, you multiply by 0.4 and then add to the sodium. So that's the corrected sodium. Dr. Jafaru. Hello, can you hear me?
Good morning. Sorry, I can hear you.
Okay, yes. So I say you posted the, yes.
In correcting the sodium, or if you have it in what they call a milligram per DL, you can use the measured sodium plus 2.4 into the glucose you have minus 100 divided by 100. So that's shorter for millimoles. Thank you.
Okay. All right, thank you. Okay, so they said let me read because there are a lot of messages. Okay, thank you. What about Dr. Shamsuddin is saying, okay, Dr. Olalekan is saying, I think the diagnosis should be a mixed picture of HHS and DK. Anion gap is 22, plasma osmolarity is around 300 without the urea. Then Esther is saying, can you go through the treatment for seizure in this patient? Shamsuddin is also saying any need for anticonvulsant. Dr. Victor is saying the brain CT scan should have been among your topmost investigations. Also, don't forget monitor in case there is cerebral edema. Then Dr. Success is also reiterating that is HHS DKA overlap. Okay, Jamila has talked about the effective osmolality being used without urea and potassium. Jafar is saying the osmolarity is should be greater than 320. Dr. Okonuga said 300 to 320 is DKA, greater than 320 is HHS. Dr. Okopi is saying, please, what fluid is the appropriate half-strength normal saline? Then Dr. Jafar is posting the sodium glucose correction formula. Please post it on the group, on the WhatsApp group. Thank you. So, Dr. Sawa, can you respond to some of these questions I just read out?
Okay. Hello. Am I audible?
Yeah, you're audible.
Hello?
Yeah, you're audible.
Okay.
You're audible.
I don't think this is HHS DKA overlap, because in HHS DKA overlap, there tends to be severe hyperglycemia with marked ketosis, with severe ketosis, which we don't have in this our patients here. Ketosis is quite minimal, so I really don't think this is HHS DKA overlap. Then I think the issue with osmolality and effective osmolality has also been
Hello?
Hello?
Yeah,
Yes,
I think you should take all the information into consideration, okay? If you look at the bicarbonate, for example, they're suggesting there's some form of acidosis, metabolic acidosis, which is usually not that common in HHS. And then if you look at all the parameters that you were given, by the time you calculated the osmolality, it doesn't seem to be falling into the HHS category. The fact that the patient had trace ketone, remember this is in the urine, you've not checked the one in the blood, there might be significant ketonemia. Okay, so with putting all this together, I don't think an overlap syndrome is far-fetched. Okay, so I think it's worth considering, and people saying it, I think they are right. It's likely that they want us to consider that an overlap. Thank you.
Yes, and Dr. Okonuga is buttressing the fact also that the pH is also low. Normal pH is 7.35 to 7.45.
Yes.
Yes. So it could be an overlap.
Okay. It can be an overlap. Thank you very much for.
Any other contribution?
Which one did the speaker eventually want to pick? Is it HHS or is it DK? But if he doesn't agree with the overlap, then which one does he want to pick?
I think I will go. I will go with HHS.
Okay, so you're going with HHS. Now, I just want to point to add to the voices that spoken earlier. The truth of the matter is, many a times, and you see this in our practice every day. You see it in our practice every day that you never really see. You always see a little bit of the other thing while the other one is going on. I'm sure many of the endocrinologists here can attest to that. Okay, you're thinking it's HHS, but you're seeing some things that will point towards DKA and all of that. Okay, but the question you should ask yourself if you think it's an overlap is, does the person meet the criteria for both DKA and HHS at the same time? And if he doesn't, then which one does he meet the criteria for? Okay, the one that seems to be closer, that has more articles that will say, yes, this is it. I know that there are, I think, 3 things for HHS, 5 things for DKA that must be there before you can call it exam. I'm not an endocrinologist, so I stand to be corrected. Okay, but if you can get all of them together, then fine, you can say it's an overlap. But if you see predominantly one, but you cannot complete the other, then better to call it the one that's more predominant. That's how I look at it. It's kind of like Dr. Remy goes when we talk about nephritic syndrome. A lot of people use it very loosely. Okay?
Yes, yes.
Yes, because somebody is having nephritic syndrome does not mean it cannot feel 1 or 2 pluses of protein. And it doesn't mean that it now becomes nephrotic syndrome. You have to still meet the criteria for nephrotic syndrome. Okay, even if you want to say nephritic in somebody with who has predominantly issues that point towards nephritic. So if you find everything you need to make the 2 diagnoses, then call it the 2 of them. Do you understand? But if you only find things that 10 to 1, I'm sure we've seen Dr. Emeka, you've seen people with nephrotic syndrome that have hypertension. Yeah, so
definitely. In fact, the common one is you see nephrotic range proteinuria. You now see 1 plus of blood.
1 plus of blood, exactly. It doesn't make it nephritic. It's still nephrotic syndrome because in the definition of nephrotic syndrome, they didn't say this should not be there. They just said what should be there. So, and it's the same thing with HHS and DK. Nobody says this should not be there. Do you understand? So if you can make out for the 2 of them at the same time, then call it an overlap freely. But if you do not believe all the articles are there for both, then say the one that is predominant. I think that's the way I would just want to look at it.
If you want to look at it from your theory here, there'll be more confusion. It's looking more like DKA than HHS.
No, but Dr. Remigus, what is causing that acidemia is because of the lactate, the sepsis. So, and that's why DK is unlikely here, the overlap. If we look at the lactate, it's going towards lactic acidosis. It's just that it's 4.5. And even we have 5 above, we say this is lactic acidosis.
Oh, they gave us lactate as well?
Yes.
Why are you assuming that the lactate is from sepsis? Why is it not from DK?
No, sir, not from DK. We hardly get it from sepsis.
Why are you assuming that it's from sepsis?
Because if it is from DK, that ketones will have been elevated, and also the random blood glucose.
Check the blood.
No, but they didn't give us blood. They didn't give us blood ketones.
Even if they did not give us, they will have given us futures that are glaring to that DK, because if it is DK, even if it is the bicarbonate should be less than that 17. If the person is having that lactate because of DK, that bicarbonate should have been less, and that blood glucose, if it has gone there in that DK, then that patient will have been long gone now. So because if this is HHS, the person will be able to accommodate the hyperglycemia before it becomes more severe that the patient presents. In DK, normally the blood glucose, of course, it can go this high, but usually it's not so high as this because they present early, because the body cannot withstand that absolute insulin deficiency. So the body needs that insulin. But in HHS, there's that relative insulin deficiency, and that's why the parameters are higher up than what we get in DK. But I think that lactate that is there and the sepsis that contribute to that bicarbonate that we are seeing and the pH that is low.
Okay, so you believe that it's more like HHS?
Yes, it's HHS, not yes.
The parameters to support. So that means there are more things to support HHS than to support DKA. Yes. So let's take the HHS.
I don't know. How about people that went for the exam? Can they say something?
Is anyone that did this particular station in the exam? What were the body language of the examiner?
Dr. Itohan, have you spoken? Your hand up.
Yes, please. I have a question. Not answering this discussion at the moment, but it has to do with the osmolarity. I just needed to clarify, if we're calculating now for this patient, we are calculating his osmolarity. Are we using the sodium as it is, or we need to get the corrected sodium first before we calculate? Is that what we concluded? I needed to be sure, please.
Okay, the people that spoke said we should use the corrected. Even though I know this is not what we've been doing, like me, that's not what I've been doing. But if that is the teaching, then that's fine. But I understand your need to clarify.
No, but I think calculating, like me, normally I don't, on a good day, I won't check it because I'm seeing the patient on the fly and in the ear, and I won't start trying to do corrected sodium. Now, I don't know what the endocrinologists do, but yes, we do corrected sodium because you need to be sure that the sodium you have is a true sodium. But I tend to do more of corrected sodium when I'm dealing with a case of perhaps hyponatremia, to be sure of the gravity of the hyponatremia.
Exactly.
Okay.
To be sure, you even need to give For example, you can't be giving somebody hypertonic saline when the person does not need it.
Does not need it, exactly. So
Chief
I can do.
Hands are up, or Chief Shoot, when you finish, let that.
Okay, Chief Okunuga is around. So I was just pointing out that, you know, if we need to do the corrected sodium before we calculate the osmolality, then does that not nullify the equation of osmolality? Okay, but I know that at that point in time, what you're trying to do is to figure out, you know, how much depleted of fluid the person is, so to speak. And that means you have to take in everything into consideration. But I don't know what the endocrinologists do now, because they seem to always change guidelines every other day. So Dr. Okunuga.
Okay, good morning. Good morning, everybody. It's good to be here.
We're happy to hear from you, Ma. It's been a while.
Yeah, sorry. So I made this slide on, so I'm just, my thoughts are based on this particular slide and what everybody has been saying. So I guess that my opinion is just that the reason why we are practicing is just to have knowledge and ability to be able to answer questions, and also to be able to attend patients in the clinical scenario. So I think that when it comes to DKA, the diagnosis will be hyperglycemic crisis. And then in the exam, depending on the presentation and what you are giving, with the knowledge that you have of DKA and HHS, you will be able to know. The exam is not hard, it's 5 minutes. You'll be able to know whether it's DKA or HHS. It's not so hard like that. So based on this slide that we are seeing, this particular slide, I'm not going to talk about any other thing outside of this slide, just this slide. There's acidosis. So I'm just going to use DKA HHS and not just go above that. It's just to say that it's usually very, very straightforward in the exam. There's no complication. And that's why they were asking the people that went for this exam, unless, you know, maybe there was just tension. If you remove tension, you can know what exactly they are asking you. They have put a pH. Again, this is recall, so we don't know. But if they put a pH and there's a pH telling you that there's acidosis, so already you know that the diagnosis will be tilting. And that is why you can never fail if you say that there's an overlap, unless it is strictly HHS, strictly DKA. Okay, but if there are things going on, and then they can now tell you to now go for that. Maybe the next question is to say which ones are in support of DKA, because we see this in clinical practice, which ones are in support of HHS. Okay, and if it is that it is a sepsis, there will also be questions that will go toward that side. And I think that's how they get all these exceptionary candidates and all that. So it's just 5 minutes. It's not so hard like that. It's just for us to know, okay, what do you expect in DK? What do you expect in HHS? So the way we always say it is that somebody comes to the, maybe to the clinic, diabetic clinic, with sugar of 400 and something, and he doesn't even know. The man is fine. He's not in crisis. But that same person, another person comes to the emergency and the person is sweating, dehydrated with that same sugar, then the person is in crisis. But when we are using the sugar, at least according to Harrison, 250 to like 600, 600 is like the cutoff for both of them, is DKA. So you can imagine 250 can just be in the house and nothing is wrong, but 250 with dehydration and all sorts of things going on is DKA. Once there's dehydration, patient is presenting with some complaints that you know is supporting DKA, because that's the sugar that they put there. 250 to 600 is DKA. More than 600 is likely HHS. And the reason why they put a lot of parameters there is because it may not, like this one now, when I calculated it, so like 600 and something. So with the random blood sugar, it was tilting towards HHS. But yeah, the bicarbonate is not so low, but it's low. The pH is low, is tilting towards acidosis. Usually in Harrison, they will put like 3 pluses of ketones. I don't have it in front of me, but from what I can remember, like 3 pluses or more of ketones. But here they will put plus or minus for HHS. Here they put trace ketones, which is more in keeping with the HHS. So if it is DKA, the ketones will be more. There will be more ketonemia, at least at the time that they are presenting, not by the time they are treating. So that may be another reason, maybe why, because the sugar is high the ketones is like HHS kind of ketones. So that may be another reason, maybe why the acidosis is not for DKA. Okay. So it's just to look at it in many ways and then make a diagnosis. But just in case the pH is really, really low, bicarbonate is low, ketones are more, the sugar is like 500 and something, even 600 on the dot, you calculate the anion gap is high. All those things will be more in keeping with DKA. So I don't think you are going to go wrong because the principles are the same. It's just the insulin doses are different, but you are rehydrating, you are giving insulin, you are correcting potassium. Remember, there will be a major catch in this question because potassium is low. I don't know whether we spoke about it. It's very low. So ideally, you're supposed to correct this potassium before you start insulin, especially in HHS because it's relative insulin deficiency. So you're supposed to give 40 to 80 millimoles of potassium chloride in 1 liter of fluid. That will come to 20 to 40 millimoles in the regular 500 mils for every liter of normal saline you are giving. And then once you correct this, then you now start giving insulin. So that's what I just want to, no need to do correction. Yes. So this is very correct. Dr. Shotubo is saying no need to, because like Dr. Why have I forgotten my guy's name like this? Mentioned that, I think so, is when you want to know the sodium, like you don't want to cause hypernatremia, because you remember that once you get to the maintenance, after you have given your fluid and you're getting to less than 250 or 200, depending on the books you are reading, you will change to normal saline. It's because you have given a half strength normal saline. It's because you have given a lot of fluid. So that's when the sodium is really, really important. But when you are calculating osmolality, the reason why they join sodium and glucose together is because they know that they are together. They work hand in hand. So you want to know the osmolality of this patient. So at the initial time to determine the osmolality, I didn't mention that 300 to 320 is DKA, and then greater than 320 is HHS. So this one now, they've not added urea and they were getting like 300 or something. So maybe by the time they add urea, maybe it will be 320, but we don't know. The person that spoke about it mentioned that it's the same value. So if you are getting a lower osmolality, then it's most likely DKA. If you are getting a higher osmolality, because it's a sugar, the higher the sugar, the more likely the osmolality will go up. So I think to calculate that osmolality, you don't need to be correcting, but to know the true sodium of the patient so that when you are giving fluids, you know what to give, then you correct. So that's my take. Thank you.
Okay. Thank you very much, ma'am,
Kunoga, you
for a
forgot my
wonderful
name. Now, wow.
contribution.
I'm going to call you a rig for you.
Yes, Dr. Shitu, I saw your status yesterday. Jare, it's you that I was talking about. You had already mentioned about the sodium and
No,
we should not
yeah.
correct it. For osmolality, but to know the true sodium, then we should correct
the true
it.
sodium, when you're correcting that, then you need to do the corrected.
Yes.
Okay.
And they should please send it to the millimole and milligram. I think they were mixing it up when they were saying to the group.
Exactly.
Yeah, thank you.
Just know one and then just stick to that one. Don't give yourself a headache.
Yeah, and please don't forget ECGO. I always talk cardiology in the management of HHS, and it's because of this potassium. So that as you are doing it, you don't want to go and cause ventricular arrhythmias. All right, thank you.
Very true.
All right.
Well done. Nice to have you around, Dr. Kunoga.
Thank you,
Thank
sir.
you very much, ma'am. Thank you, sir. Okay, Dr. Obiageli said that those that went for the exam said the answer was HHS, and then Dr. Sotubo said no need for corrected sodium before calculating osmolarity. Dr. Yasa said overlapping diabetes crisis, a mixed presentation with features of DKA and HHS, is a frequent yet unrecognized and underreported emergency. Identifying hyperosmolarity is essential as its treatment requires more aggressive fluid administration than treatment of DKA, and improper management may increase the risk of complications. All right, thank you very much for the wonderful contributions. The time is fast spent. Thank you, Dr. Jamila. Thank you,
Dr.
Yeah.
Dr. Atta. There's one other question Dr. Esther raised. I think it's important for us to clear that one too. With respect to that, this patient had seizures.
Yes.
Also in the history. So she was suggesting if there was going to be specific treatment for seizures. what our usual practice is, I think otherwise, because I believe the cause of the seizure is because of this derangement, osmolality, and all these problems that are causing the problem, not as a result of a particular underlying seizure disorder the patient is having. So when you correct all these problems that is underlying these patients, the seizures tend to automatically resolve. I don't think there's any need for specific seizure treatment. I might be wrong. So I think it's the best opportunity to clear that also here. Thank you.
On that so that we don't waste too much time. The truth of the matter is, if somebody is having seizure in this scenario, they are provoked seizures, okay? Meaning that we know what is causing it. Most likely the electrolyte derangement or the blood sugar or whatever it is. So the only thing you need to do is control the seizures if they get out of hand. But the most important thing is to treat the provocation, which is all of this, the metabolic derangement. So once we can correct that, then fine. So the person may just need something to control the seizure. Does not mean that the person has to be on anticonvulsants long term. Okay, so once you does correct, it is expected all of these things arrange itself.
Okay. All right. Thank you very much, sir. So the time has, we couldn't take this. We won't be able to take the third presentation. So over to Dr. Christabel.
Dr. Atta, thank you. Dr. Sawa, please go to your differentials. I don't know. Yes. So these are differentials. They are fine, but those that went for the exam, they mentioned that, hope I can be heard clearly. Those that went for the exam, they mentioned that the diagnosis was actually HHS, but the examiners wanted them to add lactic acidosis as a differential because of the elevated lactic acid. So that, please include it in your list of differentials. Okay. So that's about. So thank you, Dr. Jamila. Thank you, Dr. Sarr. It was quite an interactive session. I appreciate everyone that spoke. Our facilitators, our participants, those from endocrinologists, thank you so much for coming in to make the discussion more interesting and quite interactive. Thank you, everyone. Thank you, Chief Okunuga, Chief Chito, Chief Manza. Thank you so much. Thank you. I think we'll call it a day, but